Welcome to the Love is the Cure Foundation podcast. I'm Alfonso Vega.
And I'm Lyndell Vega.
Today, we get to speak with Rachel Santiago. During the first 3 months after Inigo's initial diagnosis, Rachel was Inigo's inpatient speech therapist. It is so important to have Rachel speak with us today. Her depth of knowledge in this field is very important. Her assessment skills and her ability to successfully help Inigo regain threads of communication was a sight to behold. We are so thankful for how she helped us during those early days. We feel it was her work that laid the groundwork for a continued focus on communication in all therapies for the rest of Inigo's journey. So here we go. Welcome, Rachel, and thank you so much for being with us today. We are so happy to be speaking with you.
Thank you so much.
Well, Alfonso gave you a little introduction, but we'd like to hear it from you, the professional. So tell us a little bit about who you are and what you do.
Right, so I'm Rachel Santiago. I'm a speech-language pathologist at Boston Children's Hospital, and I'm also the clinical coordinator for our inpatient augmentative communication program. And so a big part of my job as an SLP at this hospital is to focus with a dedicated role on communication access for any reason. So if a child comes to our hospital and has, for whatever reason, a reduced ability to use speech to meet their daily needs, we can come in and provide assessment and treatment at the bedside and really functional, practical solutions to make sure that the child is able to be a part of their own care and have that control and communication throughout their time at our hospital.
Okay. So Rachel came into our lives in a situation such as this when our son Inigo was diagnosed with a metastatic medulloblastoma, and he had just had tumor resection surgery. He was in the ICU for about 3 weeks. Mm-hmm. Rachel would come in to visit because Inigo had lost the ability to speak after 3 to 4 days after his surgery. And what we came to understand was that after the surgery, Inigo was now under the effects of posterior fossa syndrome or cerebellar mutism, which was caused by the surgical procedure. It's still not understood well why this happens, but it does happen to about 25% of kids who have to undergo this type of tumor resection surgery. So Rachel came into our lives during that period of Inigo's journey.
Yeah, so before we get into any of the deeper questions we have for you, Rachel, was there a diagnosis for you before you walked into that room about posterior fossa syndrome or CMS, or was that not yet in the medical record?
At least as far as I can recall, the words posterior fossa syndrome were not documented or diagnosed just yet. And that's pretty common because not every child that has this procedure develops posterior fossa syndrome or cerebellar mutism syndrome. One can't say definitively straight away that that's what we're dealing with. So I recall when I met you guys, it was probably that day 3, I want to say. I believe it was after a weekend. And we met, I vividly remember it. We met in the morning outside of Inigo's bed space. And I'm not going to assume, because I don't know what's been shared with families when I first get involved. But when I hear a posterior fossa tumor resection, my red flags start to go up. Do I need to be involved? Are there symptoms or signs that this child may be having challenges in the areas of communication that we might see? So it's not an automatic referral to get us involved. It's not something that's written down on paper just yet, which makes a lot of sense. And I had asked you guys, what had you been told prior to surgery, which I think was fairly emergent. And you had said the words that maybe this could happen. You had been told of the risk. So then we gave it a name together. And I remember the relief that you guys had to have a name associated with this difficult thing to observe. So no, at the time it was not documented in the chart. And I think part of the reason they call us in is to kind of assess the situation and see where the child's at. And as you know, one of the cornerstones is that a child may have words postoperatively for a couple of
Mm-hmm.
days, and then that ability to formulate words may dissipate over a time. So for some kids, it can be a couple days, it could be up to a week. So there's a bit of a vague post-op period that we have to sift through.
Yeah. It's so strange.
It's sadly vague,
Yeah.
but yeah, we just did an episode between just the two of us where we discussed that particular backing into posterior
The
fossa.
experience of it with Inigo. Yeah.
And it is absolutely vague, at least in our experience, because as a parent, there's so many other critical things that are going on at the same time. And sometimes you don't realize how important this particular, hey, he's saying some odd confusion things, and you don't realize that they're actually breadcrumbs leading you down a path because you're thinking about wound care, or you're thinking about other the things that you can physically
Or
see
seizures or something else.
That's right. Yeah.
So that was my thing with you, is that obviously I assume you're as you're saying, you're part of that assessment team. But I always wondered with you if you walked in already knowing in a chart, okay, this is what we think may be happening, so that you have a clue. But I think what you're saying more so is that you're actually part of that assessment team. And so you would actually be one of the people that is part of that decision-making process if a child is exhibiting symptoms of CMS or cerebellar mutism.
Right. And I think everyone on the medical team, if there's a suspicion that this is happening, I mean, I suspect they would call it what it is fairly quickly, within that first week. But yes, they do want us to get in there to assess a child's speech and language and really get to work on doing what we do, which is give access to language, regardless of what their speech skills are at that point.
I think people were afraid to. Well, we can divulge here, like you were the only person that, and we've talked to you about that before, but I think you were the only person that voiced a name to it with us. And that's why we felt a relief, because Lindy and I are both researchers. We look into things, and we had figured out what was going on. But to have you, someone part of the system, give a name to something, that gave us relief and kind of a feeling of, okay, because you want a diagnosis that you can work towards, towards success of it. And so we're the type of family that if you give it a name, we know the monster we're fighting.
Yeah, there's a path forward somewhere, we hope.
Yeah.
There is, and that with the trajectory we see with kids who have posterior fossa syndrome, there's a regaining of speech that is part of the trajectory. What that timeline looks like, nobody can say, which is the hardest piece to tell families. But to be able to say, hey, we have something we can do to help in the meantime and to help, recover and rehabilitate it is, I think, really necessary from the get-go to be able to say there's a light at the end of this tunnel where we're gonna hold your hand through it.
Yeah, that's really the unfair thing that we do to you, is we want a time frame.
We want answers.
We want to know when our kid is going to talk.
Yeah, that's right. Yeah, you and everyone else.
Yeah.
And so, according to your profession, speech language pathologist, what is the most current or best understanding of what posterior fossa syndrome is and what's it caused by? We understand it's a post-surgical phenomenon. So what's going on?
Yeah, so that is certainly a question for like a neurosurgeon or neuroscientist. So I'll do my best to keep it simple because there's certain verbiage I don't even understand as it relates to the brain. But what's really happening here, as I understand it, is, which is not well understood, I should also say, we don't have a definitive, as far as I know, singular source of what's going on, or singular concept of all the different things that are happening for every single child. But what I understand is that, our speech and language centers of the brain are up in the left frontal and temporal lobes. And so that's where much of that skill is honed and concentrated for most people. But the brain is just a big, vast, and very complicated network, and all the structures work together and rely on one another. The that fourth ventricle area where posterior fossa tumors may reside is essentially cutting off signals toward those speech and language areas, or seizing the ability to send those signals in that postoperative period. So it could be that lack of blood flow, the lack of the swelling that may occur. And I understand that there's different reasons why one person may have a less severe version of posterior fossa than another, because it is a spectrum of outcome, right? So maybe the size of the tumor, the type of tumor, the location of the tumor, all of these things can feed into the why is this happening. But the challenges that we see are not that a child has lost their speech or lost their language. It's not like it's somehow been directly affected there, but it's this sort of precursor of sending a signal to initiate a movement, to then coordinate that movement, to sequence the movements that we take for granted every day. How saying one sound is so intricate. It relies on the coordination of your breath, of your activating your vocal cords, sending air up to your mouth, and then shaping all the structures of your mouth in a specific way, and then combining those in a sequence to be fluent. It's a lot. And so when that very first signal to initiate movement is disrupted, we can't perform the skill that we've always known how to do.
Yeah. And I think in Inigo's case, he was quite affected. I mean, we did notice the symptoms emerge after like 3 to 4 days post-op, but I think in his case it was severe. I could tell that he could understand what we were saying to him, could respond in some sense where he still had his laugh. He was able to laugh appropriately if we had told him a joke, so we knew that he was inside. And from what we understood, what the team was telling us, that he could still understand, but he was quite affected, like verbally. He was not able to even force any sound if you asked him to like start making any type of sound with his mouth.
So
Yeah.
that to me, when we work anywhere we work, it's a response system, right? So we talk to people, they respond back. We work based on their responses. Difficult is that you are working with someone that you get no response from, and in very, very many ways, you don't even, Lindy's talking about Inigo always had his laugh, which was really great for us. But for you, that doesn't necessarily help you, does it? Or, how difficult is it that you don't get responses to be able to then spur what you're going to do next with your patient?
That's a really good question. I think it's important to say that I specialize in working with non-speaking individuals. So, I've been doing this for a long time. So I wouldn't use the word difficult per se, but maybe not linear. Maybe would be the first thing to say there. But we do have evaluation protocol that called feature matching assessment, where I look at the needs and the skills of the child that's in front of me, and their motivations and their interests and their supports, beyond just what are the actual skills that I can observe and elicit, and then match those to strategies that are available to that person, or that we have in our arsenal, or that we can work with, to create a communication method or system that is not just reliable, but like the path of least resistance in that moment in time. And we do that, at least on the inpatient side. It's an ongoing, evolving process. So, when I meet a child that on the surface may not be doing much, I can still gain a lot from just being present in the room with them. And I tell this to staff when I do staff education. If you walk in the room, you are a communication partner. It is on you to be communication, it's bi-directional. If you're communicating into a void, I don't think it's can be considered communication. It's the mutual understanding of information between, two partners. So if I'm not getting exactly back a message in the form of spoken words, I'm still getting a message back from anyone I'm working with. That may be a fleeting eye gaze, or that could be a gesture or body language, or maybe some formal, form of communication like an eye blink to tell me yes, or a turn of the head to activate a button, which, we can talk more about the types of strategies, but there's so many ways to unlock language for someone, whether it's through speech, which is the act of forming sounds into abstract words to communicate a message. And then there's language, which is separate from speech, which is for these kids often intact. Their formulation of words in their head is still there. It's just the act of getting it out. So it's part of my job to create that access bridge. How can I make this accessible to you? If we can just put a strategy, which doesn't have to be a thing, but a strategy or strategies for a child in place that they can utilize, then we can unlock so many messages. I don't know if that answers the question entirely, but I don't find it difficult. I find it it's a process. And we may not have the answers right away.
And that would lead me to communicate to anybody that's watching this. We observed Rachel every day as she would walk in, and Rachel is a walking sensor, is how I like to kind of explain who she
would
is.
Tune in.
Her sensor system is like it's like this microphone. It's like it's not just it's everything. She is paying attention to movements and sounds. She's paying attention to all sorts of cues
and paying attention to what the parents are saying.
Everywhere.
We had to say a lot for Inigo.
Right. Well, like a parent like me who speaks a lot must be super difficult for you, because here you trying to cue in on what your patient is.
We rely on it. No, but I think that brings a good point too of, I think a lot of people may kind of gravitate toward, I'm just going to talk to the parents because the child in the bed or in the chair, what have you, is not able to say something back to me with speech. And it's so important to like you said, tune into everything, because how Inigo may have reacted to me is entirely different than how he reacts to you guys. Like you're the experts on him, so walking into the room and learning about how to help with communication, it's so dynamic. It's so dynamic.
It's really interesting too. We fed off of how you worked. And so when you would walk in that room and we could see how you would scan and how you would look at, deal with us and deal with him, it was fascinating to watch, but it also cued us in on when you were gone to continue that same connection of our child is no longer speaking with us. However, he's speaking with us in so many other ways. So just pay attention. And in very short order, we knew who he didn't like in that room. We knew who he was happy with in that room. We know the nurse he might have liked the most, or and that's great that we were able to glean that from you and turn that into another sense for us, because with posterior fossa syndrome, you need that sense. You need to have what you do every day as a parent. Obviously, we can't gain the same knowledge that you have, but simply in observing how you worked with our child freed us to understand you need to watch for so many other things, because it's going to help you communicate with your child. So yeah, you absolutely answered that. I know what your specialty is, but I know as a layperson how difficult it would be to try to communicate with someone that doesn't communicate with you. Now, after dealing with Inigo through this situation, I don't feel the same way about it, because so many of the things that we fell in love with Inigo after his illness, we can think back in our memories now, and a lot of them are really nonverbal communication loves, which is really interesting because it builds your love in an even deeper way. It's like fluffing a feather pillow even where you fill in all those empty spots and it gets nice and soft, and the love is even more. Our memories are filled with so much non-verbal communication love, and we appreciate that, and we appreciate that we watched that out of how you worked with him, and your skills with sensing.
Yeah, the value of other forms of communication that we often overlook.
Yeah.
Yeah.
Absolutely, yeah.
So I just want to go back to one thing. We mentioned that Inigo was able to laugh. He was able to cry at times. He was under the effects of high dose steroids at the time, so that did affect his mood quite a bit. So we were able to hear him cry or shout out. My question to you is: Are these good signs that you see in recovery of speech? Does it help in recovery of speech, or how does this affect how you move forward?
That's a really good question. I would say absolutely. I think, again, I'm looking at any way, any method of communication is powerful. So if you can produce a laugh or a smile or, what we might call a non-speech sound, we could leverage that as a communicatively meaningful. And we did that a whole lot with
Yeah.
Inigo, especially in the beginning. And I do that with a lot of my patients too. I think it's important to also think about how, when we're working on speech therapy specifically, we have to focus on the neural pathways that are directly related to talking to, for communication versus, I should say, like non-speech motor movement. So, for example, blowing bubbles is not going to result in saying ooh just because you're making the same mouth shape. But with sound production, with meaningful communication behind it, that's still communication. So that's sort of part of the toolbox of strategies that worked for Inigo and worked for so many children with posterior fossa syndrome in those early days. Because if forming speech sounds is too challenging, but vocalizations are preserved, then we have to maximize that. And if they're being used meaningfully, we have to honor that as meaningfully as communicatively meaningful. Um, so yeah, and then I think the piece that is really important when we think about that sort of sound production and use of laughter and things like that is the ability or the glimmers of starting to be able to do that sort of on command or more under your own control. Because that's the piece that's really, really challenging. Sort of those reflexive, natural behaviors that we produce that we're not even thinking about, those are a lot easier for the child versus something we're saying, okay, we come in for our neuro checks every 4 hours and they say, stick out your tongue, say ah, do this, do that. For a kid with posterior fossa syndrome, that's incredibly challenging to initiate those movements. But what a joy it is for them to be able to laugh and cry and vocalize and do these things that tell us so much about what's in their headspace, even if they can't use speech.
Yeah. I remember at one point on a really nice day or a couple nice days, we were able to go up to the roof at Boston Children's, and you knew that Inigo was such a fan of music and liked to sing and play the guitar. So you were up there playing music for him, encouraging him to sing. And I just thought that was a really interesting approach because I knew that it really motivated him. I knew that he was trying so hard internally. And I thought that was such a creative way to try to, evoke sound from a child. I just thought that was so interesting that you had done that.
Yeah, I think it's important for parents to understand the toolbox that Rachel speech therapists have is deep. It's really deep, and it's incredible. Yeah, it's you cued into the things that he liked. You had communication with us about what type of music that he liked, and yeah, you went for it, and you're just fascinating to watch. Just we we spend our lives communicating with each other, and I don't think we realize the depth of what communication actually is. And so when you have a child with posterior fossa syndrome where your communication is shrunken down, and now to watch someone take that communication and extrapolate it out layer by layer, as a parent, that it's fascinating to watch because the whole world seems to take on a whole new flavor.
Yeah.
And it's really something that we take for granted as communicators on an everyday basis. We don't put enough emphasis on how important it is to communicate with our children in so many ways. And it was fascinating to watch with you on that. I would say, as you were saying, involuntary sounds neurocheck like responses that can be very difficult for a child
Mhm.
with posterior fossa syndrome. His laughter, Inigo's laughter, became like catnip for us
Yeah.
because, as we used to say, we became dancing bears
Mhm.
at a certain stage in Inigo's
Yeah.
care because if he was laughing, it felt to us like he was having some sort of joy. And
Mhm.
to us, that fed our souls, and it seemed to feed his soul in our connection.
Yeah.
And so we tried to do so we cued in on how you communicated with him on certain things, and so we started to develop our
Yeah.
own languages using some of the stuff that you
Yeah.
would do. In one instance, we created a pain scale because with, kids in the
Yeah.
hospital, you have to have a pain scale, and they come in and they ask them or they show little smiley faces. I don't know if you have that on your badge, but they have little faces.
Oh yeah, no, and we gave one to
Okay.
him too that we provide because we don't like I don't love
Okay.
that one. I don't think it's very child friendly.
Yeah.
So we have our own that we hand out
Yeah.
too.
So we had a pain scale that we did as a family that was appropriate for a 9-year-old boy. And so it was the idea of like, if your belly hurts, does it hurt like a taco? And so we would talk about tacos, and it was this whole like thing. And we won't divulge it all here because there were other medical issues that were going on at the time that made sense. The taco made sense. And so,
Yep.
um, but this was based off of something that you had done with him and you had talked to us about, which was don't narrowly focus on something that is told to you in a specific way. Look into things that spur him and spur
Mhm.
something that
Mhm.
that would awaken something in him and
Mhm.
his ability to communicate with you that only you guys would understand.
Mhm.
And
Mhm.
so
Mhm.
we thought that was a great strategy because as parents, all parents are like this. You have connections with your child that no one else understands. So of course the medical world is going to tell you, "Oh, this is how you do it," and they're going to hand you a little pain chart and like
Mhm.
this is what you do. But you said to make sure to that's fine, but maybe like look at something more interpersonal with him. And so we did that,
Yes.
and it was
Yeah.
such a good strategy that we integrated into everything that we did from with him from that point on was okay, this is what we were told, what we're being told in treatment. How can we personalize it to something that he would more connect with?
Mhm.
So our pain scale
Yeah.
was, yeah, it was something he loved.
Yeah.
Yeah. What also helped is that Dad and Inigo had a connection where, they would tell jokes to each other all day. Inigo, before he was diagnosed, was homeschooled and Dad would help him with homeschool. So they had a really tight connection with that type of humor. And
Mhm.
Alfonso was able to use that to really augment the the
Well,
communication between you
yeah.
and Inigo. Like you were saying, you had to be the dancing bear, and he
Mhm.
did really respond to that. So it's something before diagnosis that you had that you could really count on in that moment, to connect with Inigo.
Well, and I say this a lot, and it's a little bit odd, but the pandemic was a blessing for us because I
Mhm,
stopped working and
Mhm.
Inigo was homeschooled from that point on. He was in school before that, but it was something that was a blessing for us because we became so close
mhm.
on a lot of
Yeah.
our communication and a lot of our um, maybe adult humor that maybe shouldn't have
Well,
been.
he was an only child, so the humor he was exposed to was
But
was different probably from most children, but
not inappropriate,
not
just
Yeah.
inappropriate, but
yeah,
No, no. Well, he had an old
yeah,
soul though. He
he
really
did.
did. It's appropriate. No, but I think you bring up such an important important thought of, first of all, like I said, parents are the experts on their child. I cannot walk in a room and not lean on you guys for your expertise. Maybe you can call me an expert on communication perhaps, but I am not an expert on the patient. And I wouldn't be able to build that rapport with him if I hadn't seen or observed those like really intimate connections that you guys have, because you each have your own wavelength, with Inigo, and every parent does with their child, every caregiver does, because sometimes grandma's at the bedside during daytime hours while a parent works, and they have their own sort of banter and connection and process of communication, and so you do really have to sort of like synthesize all of it to keep it person centered, and I think that was really the key for Inigo. And the key for so many of my patients, especially with this sort of acute reduction in speech, is to really tap into like, well, who are you as a person? I don't know you before this massive change. So I need to kind of lean on those experiences and connections and relationships to kind of develop a plan.
Yeah, and I want to cue in on something that you said there. We are in this type of environment. Lindy and I are rule followers. We understand that the system has more knowledge than we do, and we respect that. And so, as we worked with the therapist, as we worked with you, we understood that we had to do it in the way that the system, whatever medical teams we were dealing with, we have to go through that process because we really want our child's health back, And what I was saying earlier is you enabled us to realize that you can do all of that. You can respect the system, you can follow the rules to try to attain some sort of health, but tailor it to your personal connection. I think that's really, really special for parents to understand is continue being that same parent that your child always knew, even through this process.
100%. I've had people tell me that their kids may feel more like scared or have a difficult time coping because their parents are acting differently. Like, am I in trouble? Like, I think we forget that kids really feed off the energy in the room. And they're so observant and so inquisitive. And that's why it's so important to communicate directly with the child. I can't emphasize that enough. And that level of transparency is so important, developmentally appropriate, of course. And that's why our child life colleagues are so critical to care as well, because coping is sort of their expertise, but the ability to really individualize what we do, because it's not about me. And, the if I came in with a checklist, that really wouldn't help us at all. It's really about Inigo. It's about every child and what are their specific needs and really meeting them where they're at.
So I just want to go back to something that you had mentioned before. We started talking a little bit about the augmentative speech therapies that you offer. So what are they, and what types of resources are available to kids and their parents to just get speech going again?
Yeah, so augmentative and alternative communication, we call it AAC. It's essentially strategies that, beyond just the use of speech that we use to communicate. And I think we take for granted we do it every day. Sending an emoji in a text message, that's augmentative communication. Um, for Inigo, I think I gave you the whole library of tools, but essentially we have two overarching types of strategies that we might recommend. Those are called unaided strategies and aided strategies. So an unaided strategy is a way of communicating that's just intrinsic to your body. You don't need outside tools or materials. So, like we said, maybe raising an arm to say yes, or squeezing shut to tell no, or using eye gaze, or what have you. And then there's aided strategies, which are those tools and materials or outside things that we bring in to provide communication access. So we're very fortunate at Boston Children's Hospital because we've been having this inpatient service for like 30 years now. Our outpatient program is very robust, And so we have a really great lending library of tools. Not every hospital has access to that. So my answer is definitely going to reflect what we have available to us, the resources we have. But one of the primary things that we provide are just called communication boards. Maybe putting pictures or photographs or typed words in a grid on a page that a child can point to or say yes while we scan through the options, or use eye gaze to look directly at their message. And we can make those messages what we call a pre-stored message that says a whole sentence for you. I'm feeling hungry can be the message, and it has a picture of eat. Or maybe a child can select multiple of these targets to construct their own sentence. We have things like different voice output aids that maybe we record a message onto these, or we use a synthetic, computerized voice that speaks the message out loud. So when the child selects it, maybe it speaks it out loud on their behalf. We have some really fancy tools like eye tracking technology, whereby we have a computer that is controlled through a calibrated eye tracking system that's calibrate with a child. They can use their eyes to dwell on these different words and messages and have that voice output paired with it. But then we have systems that are so simple but wildly effective, like the communication flipbook that we did with Inigo, whereby we have tabbed pages like you do in a binder, and each one represents a different category or topic. And we go through those together with him. And so there's a lot of different tools for the toolbox, like I said. And we're not just picking one strategy, we're thinking about a system. Lots of different strategies that we might pull from based on, what the child's specific needs are.
We had a button. We had multiple buttons.
You did, yeah.
You had set up buttons next to his head, and then so at the point where he could finally move his neck and head, I forget what month that was. Month 2.
Yeah, I think it was the month before he went into intensive therapy. Yeah,
where he could
rehab. Yeah,
you had him, and then you had recorded voices. Whose voice was it?
It was yours.
It was my voice.
Yeah.
It was yours. And we gave him the choice. He was in control the whole time. Whose voice do you want? What should it say? We would give him options. Do you want it to just say yes or yep or that's it? Or, just keeping him in the driver's seat, even if it couldn't be his voice. We call that a proxy voice. So yeah, you did record for him.
I think that meant a lot to him to have the power of choice over those things.
Mm-hmm.
So that helped too.
He Inigo always had autonomy. We in this home, he always knew he had a choice, or he always knew he was part of the decision-making process. We always included him. He could feel important. And we needed to make sure that we kept that inpatient too. When your child is not speaking, is not communicating the same ways that you're used to, you don't know how to give him that. And so for you to give that to us as a tool, that was fantastic. And then we cued in on that, and we said, oh, okay, so for things that we think aren't important, you can still do that. Okay. So of course we're dressing him and you're just putting his socks on, but no, like give him a choice between this pair of socks or this pair of Bigfoot socks or this pair of Bigfoot socks, and then pick which one. And it was, you enabled us to understand that, continue those strategies of choice, continue those strategies, because it is communication. It allows him to have, a part of his care of what's going on every day. And so here he was hitting a button with his head, and then he could, which pair of socks do you want? And he would hit the button for, the right or the left or something. And yeah, it's just so interesting how you're still communicating. It's just different.
Yep.
Yeah. And
it's just a little different.
And as little as you think your child may be able to do, there's still something that I just want to point out to our listeners that the therapist will be able to tune into and help you realize, like, there's still some functionality here that we can use and, use that to help this child.
Yeah. And that's what I'm saying. A lot of our memories now, that fill in the rest of our love are non-verbal communication. And we have such good memories of doing these things now that aren't his voice. It's just him making, minimal actuations to indicate certain things. And it's so sensitive. It's such a sensitive thing. But as parents, we had to learn that you're communicating just on a different, more elevated plane, I would say, to other parents. It's a more elevated world. You're dealing with all sorts of, indicators.
Yeah. Another thing that that you tuned in that really helped with Inigo, he had a lot of varied interests, which a lot of kids do at that age, but you really tuned into that. You were able to bring in a lot of other programs and therapists in conjunction with what you do. Would you talk a little bit about how that helps you in speech therapy with these children?
Yeah, absolutely. I should say that I think the first few weeks working with Inigo, he was like not obviously very pleased with working with me because everything felt really hard. And that was totally fair. And we were in sort of that, well, we've got to figure out the kind of sweet spot system of what's going to be easiest and most effective for him. And it didn't happen in a day. That was really important to point out. It didn't happen in a day, although we did have some strategies that were really helpful. And the turning point for him to almost like be available to participate in a way that really started to benefit him longer term was when we tapped into his interests. And that was a very deliberate decision on my part. I'm not just going to come here and try a bunch of stuff. That's not functional. What's functional is having Inigo play Jeopardy. We were trialing the eye tracking device, and my student programmed a Jeopardy game. And every single question was about one of his interests. And I knew absolutely nothing about those interests. I don't know anything about RC cars or Bigfoot or like his very cool bands that he liked. And every question was about those things. And so he won Jeopardy. And like, how cool is that? He totally schooled me. And we were trying some different strategies, but doing it in a way that felt really highly customized and person centered. It's not about me. It's not about the tools. It's about Inigo. And I do that with all my patients. And actually, at that time, I had a few other kids I was working with a more severe form of posterior fossa syndrome, and same rules applied. And so I could only do so much because I find myself to be a creative person outside of work, but I don't have the same resources as some of the other really wonderful programs at our hospital. So the first person I thought of was Lockie, who is one of our artists in residence. And Inigo had such a vibrant interest in his comic books that he had written and had always, I think, wanted to make a movie about them. That was something, maybe he had already started that before his diagnosis. And I thought, well, we can talk about that. Let's put Inigo, he's the boss. If I'm in your patient bed space, like you are the boss. I am not the boss when I'm with you because we have to get communication going. And we made a sort of choice making, I don't know, decision tree of sorts so he could direct his own film. I can't make a film, but Lockie can. And so we kind of combined forces and did a lot of co-treatments together so that Inigo could communicate and then by virtue participate in this really amazing activity that was highly therapeutic for him. I really feel that way. And I think we made like three Lockie movies. And then we brought in Ginny, our writer in residence, and gosh, they did a ton of stuff. Certainly after he regained his speech, I do recall as well. And with child life programming, we did a lot of co-treats with physical therapy and occupational therapy too, because it's all about participating in these functional activities. And I can only do so much of that alone, and you can only do so much of that alone. So that collaboration is it's really magical.
Yeah. We did just see the participation level. His participation just shoot up when he was able to combine all these therapies and programs. I feel like he kind of took off from there. He just started to regain more and more functionality with his hands, turning of his head. He was to the point before we left Children's for Spalding rehab, he was able to like get full thumbs up. He was even able to tell people how to leave, like it was time to go. He was always given like his chops.
That's right. I forgot about that. Yeah.
So
my favorite, though, I think my favorite is I always gave him the option of letting you guys tell stories about him and his interests and things. And he gave you permission to tell me about a specific picture that you had of him doing this like movement that the kids did at the time. And he hadn't been able to create that movement. And I said, or I think you said, Alfonso, oh, I'll show her what it looks like. And I said, no. Then I go, why don't you try? Because again, it's all about choice and control and trust. And he just went whoop, and he did it, and it was such a cool moment. And I think there were like 3 therapists in the room at the time.
It was
but yeah, it was such a turning point to like tune into
the first
him.
dab he was able to do, and it was. I mean, I think Lindy and I were just
we were all shouting,
believe it. And then
I think nurses came in the room like, "What's going on?" And they're like, "Yeah."
One of his oncologists, I remember, she had come in to watch the therapy session because he was just starting to do more and more. It was near the time that we were moving on to Spalding, and here he was doing a dab, and it was we just couldn't believe it. We were so excited. I just want to point out once again for people what Rachel is saying here is so important. This therapy and the therapy that she's talking about is what enabled Inigo to feel that this was geared more towards him and what he wanted. Where when you're in physical therapy, when you're in occupational therapy, these are just normal day processes, like learning how to walk again, these aren't things that are about you and your character, right? You have to brush your teeth again. Everybody brushes their teeth. Once again, it's not you and your care. There's nothing personal about that. But this therapy and what Rachel is talking about was reaching into Inigo's interests and allowing Inigo to understand his interests were important. And that is such a spur. When you reach into a child's creativity and they can realize that this is about them, they are going to work for you on a whole different level. Because they're going to feel valued through this process. And one thing that we always say about Inigo is he was very, very aware of what he had lost. And giving him a therapy that enabled him to feel that people cared about his interests, I think what it did is mute some of those losses for him. And he would say, fine, this is where I'm at, but I can still exhibit or show people what I'm about. And I think that's so important for children with CMS or posterior fossa syndrome in your communication therapies to understand that there's a real child in there still. There's a child that still has creative wants and endeavors
and
that
desire to express themselves and share themselves. How important that is.
Don't lose that because there's a blank stare or there's the communication isn't the same or the laughter isn't the same. Like, understand that child is still there. It's still there. And it's just going to look different at this point, But Rachel, it's I have to say it's incredible that Inigo passed away a year ago now, and then we hadn't been under your direct care for a year before that. And I can't believe your memory.
I know. It's so clear.
On the care. And it's amazing what you do for kids. You remember.
He was such a vibrant kid. I mean, I learned something new every time I walked in the room, which, and again, it's because he had so many interests and I learned something new every single day. Really, truly.
Rachel used to do something really, really special. She would, when she would leave on Fridays, she would come in on Monday and she would bring back a joke from from her kids. And it was just awesome because she would bring back a joke for Inigo, and it was so cute. It was so cute to see you made it personal for him. You made him really feel that you weren't just a therapist, that you were someone that actually cared for him. And I think that's so special for kids to understand that people care for you. Your therapists care for you. And I know the adult environment in a hospital wouldn't be the same, but I love what you guys do systemically at Children's, which is to make children understand that you are there for them and they're important to you. I think that's really special.
Mm-hmm. Yeah. So moving forward here, we just want to talk a little bit about the differences in developmental stages. So Inigo was 9 years old when he was diagnosed, and he was already able to speak clearly, form full sentences. He was reading, writing at an appropriate level for his age. What are some of the challenges, if any, in accommodating speech in the earlier developmental stages?
It's a really, really good question. There's a few. I mean, I think one of the challenges that these much younger kids face is they're in a really critical developmental window. And a lot of that development occurs in, the real world where we have such dynamic experiences and we're communicating with lots of different people. Perhaps some kids are in daycare with same aged peers. In the hospital environment, it's not the real world. As much as we try to normalize it's not the same experiences. And so the one concern is, these missed opportunities, or how do we give that back and make sure we're still giving that child a way to gain their skills. And maybe that's a bit on pause during those early weeks or months. Um, but we really want to, again, it's about that access to communication. And for a younger child who's pre-literate, we can't use all the strategies in our arsenal. We kind of have to think about the developmental stages of language development, symbolic knowledge. So, for example, that uh, an object represents a word, but do they understand a photograph also represents that word? Or a symbol, like a line drawing of a cup, represents my cup in real life. Those are cognitive skills that we learn over time. And so I have to think about those things when thinking about the strategies that work best. In terms of developing, spoken language and using speech, there's still a trajectory of recovery that we're working with. And so uh, kids will gain their speech back, and it may not sound exactly the same as it did before, but younger kids they are primed to work through a lot of that and really try and close that gap. But yeah, we really want to make sure we're thinking about their cognitive skills, their speech skills, their language skills, because these are all
Mm-hmm.
developing. And so that's why that post, rehab care is still so critical, that longer term oversight to make sure we're still developing the skills that we would be developing otherwise.
Yeah, this question kind of spurred me to look into some other things, and I came across a study done by the NIH, or something that they're still working on, and the idea being that more attention needs to be paid to the communication skills of children preoperatively. So a child that has not been diagnosed,
Mm-hmm.
that hasn't been where they're brought in for developmental
Delay. Yeah.
delay.
Mm-hmm.
And
Yeah, that's right.
the idea that don't just cue it up as developmental delay. After testing, when a diagnosis of developmental delay is put on of some sort, also do what they are considering simple, which is do some scans, do some extra look ins to make sure that there's not something going on inside this particular study. And I'll link it below in the show notes, but it had to do with a case study of a 3-year-old. And this is what we didn't have with Inigo. Inigo was already past the stage of developmental communication. And so
Yeah.
he, in so many ways, was so adaptive. He had also broken his leg the year before. And so we did not see, of
The
course,
sign.
he
Yeah.
was healing within that year. And so we never saw balance issues because he had broken his leg and he's still working on getting all of that back.
Strength. Yeah.
Not only that, but a month before he was diagnosed, he was back in for surgery to remove hardware in his leg. So there was a
Mhm.
lot going on for us in particular. And we don't want to scare parents, but I do think it's very important, as this study shows, pay attention and don't just assume that it is developmental delay. Maybe ask more questions about, are there other possibilities that we could look into, just to be clear. Because in the study, something that they point out is, once a scan has been done for a child that has developmental delay, they should be put on a list to get scans done continuously after that, to make sure that there is not a lesion showing up, that there is not something else
Mhm.
there. So sorry, Rachel, I don't mean to just drop that.
No, that's actually a really good point. I didn't touch on the
Mm,
preoperative considerations as well. And I think you make a good point that noticing or observing changes in how you're communicating or thinking, it's a lot less obvious than those physical skills, which if someone has a gait issue and their balance is off or their vision is blurred or doubled, that's a pretty tangible thing to observe. But for a young child who's still developing their language skills, it may be really hard to notice those nuanced changes if they're occurring beforehand. So you're right, it's important to pay attention. The developmental delays can happen for so many different
mhm.
reasons. But yeah, your power is advocating and asking questions as a parent.
Yeah. So my next question is, this process is going to require a lot of patience from the family, the parents, and the child involved. And sometimes it may seem like therapy is getting them nowhere. Um, why is it still important to continue with the therapy, even if it doesn't seem to be helping at the moment?
A great question. I hope I touched on it a little bit already in that, communication is still there, right? So even though we're working on speech in different ways throughout the recovery continuum, communication is central. If you have intact language, even if you don't, even if that's something we have to work on, communication encompasses connection, control, developing trust, participating in your care and telling about your symptoms, or opting out of activities. The ability to say no and leave me alone is like the most important thing to children when they're at the hospital. And how are we going to give ways to do that without some kind of intervention? Whether it's something really small, like a yes, establishing a yes response, which, yeah, maybe it doesn't happen that first day. And I think Inigo is a great example of that. We saw an evolution of changes over months. And what we were doing day one looked vastly different from the next week to the next week to the next week. And I like to tell families, it becomes hard when you're doing something every single day to notice those changes. It's a little easier for us to come in the room, after a 3-day weekend or something, to say, wow, like I already see these incremental gains. So it may feel really slow. It may feel like nothing's changing, but again, we're all part of the communication, right? So we're all learning, we're all evolving together, and we have to keep assessing that access piece. What is working, what is not working, what can we change? What can we keep moving toward? And I think posterior fossa syndrome is really tricky because a lot of kids, the inability to initiate speech relies on things that I can't, fix, right? Or no matter what type of therapy I'm providing, we still have to wait for, it's like a domino effect. Maybe we have to wait for that swelling to go down or for the blood flow to improve or whatever it is. But there's still so much we can be doing in the interim so that the second speech is more accessible to a child. We've already laid the groundwork. It's sort of like, the house is on fire. You have to put it out first before you can rebuild
Mhm.
it, or you're not going to get very far later. So that's why it's really important, I think, to really focus on communication, total communication, all the different ways we can communicate, and then sort of hone in as that speech, the availability to produce speech really starts to
Yeah.
return.
We would give Inigo pep talks all the time, because we knew he was frustrated that it wasn't moving forward. I think he would hear the stories every once in a while, like, "Oh, kids with posterior fossa, sometimes they'll wake up and they're talking again, and they're back to who they were." that I think frustrated him. He didn't like hearing that because in his case that was not happening. And
Yeah.
it was giving him pep talks to understand to be patient with himself, us continuing the care that we were trying to do with him, you continuing what you were doing with him. What you did with Lockie was it's incredible how you guys work like a symphony and how it's so seamlessly integrated. For anyone not in the New England area, the Boston Celtics just won the championship last night. And
Yeah.
one of the videos that he did with Lockie was about Jaylen Brown, who was his favorite player 2 years ago, and it was, once again, you were queuing in on his interest. Inigo, you like basketball. Who's your favorite player on the Celtics? And you went down these paths, and it was doing those things with those other specialists that enabled him to walk back from that impatience that he had with himself, where it was fine. I'm not talking again, but guess what? We're working on movies, we're working on books, we're working on my creative interests, and that really dulled his frustration with not being able to speak again. So it's great how you do that, how you understand enough to. I know you guys are awesome. But I know I just say that.
Also, I will say though, no, but you guys are awesome too, because something that you've done and something that I see a lot of parents do that I think is really an important consideration is acknowledging those frustrations. Like, this is hard. I see how hard this is. Because if a child can't express that the way they're used to expressing that, they may not get that reassurance back, right? So we need to give away, like I said, to opt out or to talk about things that feel difficult, because just because we don't want to talk about it, it's uncomfortable for us. Imagine holding on to those thoughts and not getting that reassurance back that, like, hey, we're going to get through this. We're going to work on this together. This is really hard. This totally
Yeah.
sucks. But like, we can do this and we're going to work hard. And I've heard a lot of kids, especially older children, tell me, like, oh, I don't want everybody cheering for me. Like, don't throw me a parade if I took 3 steps. I want to take 17 steps. I want to walk up the stairs or whatever. And so it's so person dependent. Some kids like just get so motivated by that, but you have to tune into,
Mhm.
what are your needs? How are you going to get through this in a way that feels, approachable and acceptable
Yeah,
to you?
you never made it feel like a checklist for him. You always made it feel like it was about him. And
Yeah.
that's so important because you're right. Sometimes he would look at us and he would say to Lindy all the time, because she would always call him handsome or cute or something. Oh, Inigo, you're so handsome. And he would look at her and be like, what's wrong with you? I know what I look like. And it was this idea of like, oh man, it was making sure that he understood that you're always going to be handsome to us. And I know that you want to look a certain way or you want this and that. Don't praise me, he would say
Yeah.
essentially, for doing things that are not praiseworthy. And we would just let him know
Mm.
small miracles are just as important as big miracles.
But he was able to express that feeling he
Yes, he
had,
was.
like, I
Yeah.
don't feel this
Yeah.
way
Yeah.
anymore, guys. I know I'm different. And,
Yeah.
regaining his speech was just so important.
Yeah.
It was,
So Rachel, I know we need to let you go,
yeah.
but one of the things I just want to close off on a couple things. We, after Inigo's initial resection and radiation treatment, we worked for about 3.5, almost 4 months with Rachel intensively. And that really laid the groundwork to help Lindy and I to understand that this is a forever journey of communication in all facets. We moved on to Spalding, and at Spalding, Inigo had a different speech therapy team, talk therapy, that sort of thing. At that point, we requested of them that what was most important for us to get out of speech or language therapy at that time was having Inigo simply be able to eat. Because at that point, he was not able to eat. And for parents, for you to understand eating, speech therapy, it's all, Rachel, you would do a better job explaining this, but it's all interconnected.
It's in our scope of practice. We do both things.
Okay.
Yeah.
um,
Yeah.
but what
Yeah.
Lindy and I thought was most important at Spalding was we felt with what we were seeing with him that speech was coming down the road, verbal communication, but we wanted
Mhm.
safety in us being able to bring him home for the first time, eating and drinking on his own, and not have to worry about an NG tube or NJ tube and those sorts of things. So we felt that was important. So what we did at Spalding, what we focused on was actually food, eating. And so that was interesting too, because I'm sure you deal with this all the time, but the love of food that kids have, or that some kids have, really spurs their growth
Yeah.
in this path. So that's what we did there. We ended up leaving Spalding back to Children's as Inigo began his systemic chemotherapy at that point. And at that point, we didn't get to see Rachel every day because the service changes. And it is what it is. But we would see her every once in a while because Rachel's a therapist that still, she keeps that connection. So she would still pop in the room as she was probably going into every single other room that she needed to do therapy with. And she would still connect with Inigo. And that was something that he absolutely loved. So we can fast forward to the point where we are ending or landing the plane with Inigo. And, we asked for Rachel to come in because we trust Rachel's wisdom through a lot of these processes. And at the very end, we were having a difficult time communicating with Inigo. And I think this is important for other parents to know in a very similar situation. Communication towards the end of life it can have so many different avenues that it can take. There are chemical changes going on. There's all sorts of things going on that your child has no control of. Your medical teams have no control of. You have no control of. And you kind of just have to ride those waves as they come. And so we called Rachel in because we thought, is there something? Because we saw Rachel like a superpower. Like, is there something, Rachel, that you can do? And so she listened to our concerns, and um, she kind of took everything in that we were saying, and she said, you know what, I'm going to get back to you on this. And so um, I don't know what you did or what you needed to figure out or whatever. But by the time you came in the next day, Inigo was completely, we were on a different wave. He was fine. He was not.
Well, you had said to me, I don't know which version of Inigo you're going to get.
I did.
There's going to be like the Inigo you remember, or maybe this other,
Yeah.
version of him.
Yeah. So you came in the next
great.
day, and you and Inigo proceeded to have like a 45-minute conversation on your interests, his interests. And as parents, it was beautiful to see. And it was so poetic at the end of his life that this was his closing of the book.
It felt full circle for us, Rachel, that you came in and talked to him.
It did for me too, yeah.
Yeah. It was like his goodbye with you. And it was beautiful. It was really amazing to see you sit there and just talk with him. And it was no longer about therapeutic care. It was about like heart to heart.
Yep, just the connection.
Yeah, it was so cool. And we have pictures of you and him sitting there talking about your interests, your mutual interests for small
miniatures,
which it was astonishing we hadn't had that conversation prior.
It was perfect for the end.
It was perfect. Yeah. No, I think a lot of speech language pathologists don't maybe realize their role at that point of care, we'll call it. But you're right, it's a bookended experience, but the goals are still the same. And the goals day one when I met Inigo, and to that day that we talked about our miniature dioramas and things that we love, was connection and control and trust. And I firmly believe, at least in the acute care environment, those are like the 3 gold stars if we had to have a checklist. And my job that day was to hang out, to connect with this little guy who I had been connecting with for so long, and to give him space for control. And I mean, he led that entire conversation completely. And I was subtly doing, my job under there. It was a social visit, but it wasn't all social. I was, feeling out his skills at that point so that I could support him and you guys with, the smaller challenges that were sort of brewing, but really it was about connecting, really truly. And so it really was a bookended thing, but the thread of communication is what carried everything, I think.
Yeah, well said. We're so appreciative of the work that you do. We're so appreciative of the wisdom that you have. We're so appreciative for the work that you did with Inigo and with our family. We understand that. And in these sorts of cases, it's not only about the child, it's also about what you do for the parents, teaching us and walking us down the road of understanding that we, in so many ways, have to become communicators in different ways, more holistic ways. We need to become sensors, parking sensors, and understand like where that communication is going to come from. And your ability to teach us in that moment in real time as we were in the middle of the fight, is really such a testament to I don't even know if it's your profession or just you personally, because I have a sense it's you personally. That's just who you are, because we saw you interacting with other people in the hallway as we would be going somewhere else, and we can tell the type of person that you are. And it's just we realize for you to integrate that and how you work with us is really a special way to carry for your profession and who you are as a person. So,
and it was such a gift to us and our family.
We appreciate you, Rachel. We're so thankful that you spoke with us today. And the truth is, we could sit here and talk to you for like 5 more hours, but
we absolutely could. We'll make a 3-day podcast out of it.
Thank you. Thank you for being with us.
Thank you, guys.
That was our show for today. Thank you for joining the conversation. We hope that in listening to our conversations, you will be able to glean information that can be useful for you. If you find that the Love is the Cure Foundation's podcast would serve someone you know, please share our content and support our cause. Our desire at the Love is the Cure Foundation is to help children and families as they navigate a pediatric brain tumor diagnosis. Our experience is with Inigo's brain cancer diagnosis. Some of our conversations may be specific to brain cancer and the residual effects. That being said, through these conversations, we hope to impart practical information that may be useful to a family that may need it as they journey with their child through a pediatric cancer diagnosis, brain cancer or otherwise. Our conversations will continue as we speak with people from different disciplines within hospitals and other cancer situations. We are a nonprofit charitable organization. If you would like to donate to help the Love is the Cure Foundation, please go to our website, loveisthecurefoundation.org, where you can donate and also read about our story and the outreach that we are doing at the foundation. Thank you. And as we say here at the foundation, go love on someone. We all need it.